The problem is that anybody who tries to lose weight is actually fighting their biology. It's fair to say that that biology is actually there to protect us from weight loss.
Hello and welcome to the Scale Up Your Practice podcast brought to you by Obesity Canada. I'm Dr. Roshan Abraham, a family physician and associate professor at the University of Alberta. In today's episode, we are going to be talking about obesity as a chronic disease. We wouldn't treat hypertension with willpower alone. We wouldn't ask someone to prove they've tried hard enough before offering care. So why is obesity treated differently? Today, we're looking at the biology, the neurohormones, the genetics, and the physiological defense of body weight so care can match what we know. To do that, we are joined by the person who literally wrote the book, or at least the guidelines on this. He is the founder of Obesity Canada, the Canadian Association of Bariatric Physicians and Surgeons, the creator of the Edmonton Obesity Staging System, and a global leader in obesity medicine with over 500 peer-reviewed publications, known to so many in the community that is obesity care across the world, and a driving force behind the landmark 2020 clinical practice guidelines. Dr. Arya Sharma, it is an honor and a privilege to have you on this podcast.
Hi, Roshan. Good to see you.
Just as a reminder, today's episode is supported by an unrestricted educational grant from Eli Lilly Canada. We thank them for helping us bring this podcast to healthcare professionals across the country. So, Dr. Sharma, you founded the Canadian Obesity Network, now Obesity Canada, in 2006. Back then, calling obesity a disease was controversial. Even today, despite many obesity guidelines, we see our systems are ill-equipped to treat obesity as a disease, leaving it up to individual clinicians, patients, and the public to pick up the slack. Why does the concept of obesity as a chronic disease still feel like the point we keep getting stuck on? Why is shifting our mindset from lifestyle to medicine the prerequisite for everything else?
Well, I think the biggest mistake that most people do when they think about obesity or try to tackle obesity is there's an illusion of control. People think that weight is something you should be able to control. And the solution to controlling your weight is, controlling calories in, calories out, which means that, if you eat less and move more, you should potentially be able to be at whatever weight you choose to be. The illusion is created largely because when people go on diets, they lose weight. And in fact, when I look at my practice, I don't think I've ever met anybody, who comes to an obesity clinic or a bariatric clinic who has not already tried countless diets and they've tried over and over again to lose. And in fact, we know that there's a huge so-called weight loss industry out there that creates the illusion that, if you try hard enough and if you follow the diet, whatever the diet is, whatever the fad, the latest fad diet is, or if you join the gym and you get your personal trainer and you work out every day, you should be able to somehow conquer your obesity. And there's a lot of money to be made with that. And so we have this huge industry that is giving you these messages. And in fact, you keep meeting people who tell you that they've lost significant amount of weight, and they'll tell you whatever they follow. They'll say, this diet worked for me or this exercise program worked for me. What they don't often tell you is, or what you don't often see is the fact that the vast majority of people who, do these diets, do these exercise programs, successfully manage to lose weight, end up putting it all back on. And usually the excuse for that is that people are just not trying hard enough, that they're not persistent enough, that they're not really, sticking with the with the diet that works. When in reality, the problem is that anybody who tries to lose weight is actually fighting their biology. And so, we have to have the first step to understanding obesity is understanding the biology of how the body actually regulates its weight or its energy stores, if you want to look at it that way. And that is a very, very complex biology. And in fact, it's fair to say that that biology is actually there to protect us from weight loss. And so anytime anybody goes and tries to lose weight, no matter how they do it, ultimately they're fighting their own biology, which is trying to do the exact opposite, and that is to keep them where they are. And if they somehow manage to lose the weight, that biology is actually there to make sure they put the weight back on as soon as they stop doing whatever it is that they're doing. And that brings us to this whole notion that once you have obesity or someone who has obesity, it kind of becomes a lifelong struggle because anytime you try to lose weight, you're going to be fighting that biology, and that biology, unfortunately, never gives up. So even if you've been successful over many, many years in losing weight and keeping the weight off, it doesn't really take much to put all of that weight back on. And I know that is very frustrating, and this is not a happy message, but it does explain why so many people are struggling to lose weight and keep it off, and end up by blaming themselves. We talk about internalized stigma, so people are really beating up themselves, or they get beaten on by other people, for not keeping the weight off, when in fact, they're actually dealing with their own biology, which is hard to overcome. In fact, actually, there is no way to overcome it at the end of the day, because it's always going to be fighting you.
I can't tell you how many times, as a family physician that does comprehensive family medicine, how many times I just had somebody yesterday who essentially said that if they just wanted it enough, they could change their weight. And some of the unlearning that we all have to do around weight starts with addressing that internalized blame. But at the same time, which is what I'm trying to do as well as a practitioner, is that the science can actually tell us something different. So actually breaking down that biomedical reality is essential for patients to reframe the way they think about it. So can you break that down for us and for our listeners? Because I do think that is essential for a lot of people to understand. So when a person cuts calories, what is happening physiologically in the brain and the gut that makes this long-term sustainable weight loss unattainable for many patients using lifestyle interventions alone?
We're talking about a very complex biology, but the concept is really very simple. Energy stores are vital for survival. I mean, the reason we are here and the reason our ancestors survived was because when there was food available, they were able to, eat as much as they possibly could. Clearly, they didn't need all those calories. I mean, this was way more calories than they needed, and those extra calories, they get stored as fat. The idea is to eat as much as possible, because you never know when the next meal might come along. And so there's a biology that kind of drives us to consume food beyond what we actually need at a given moment. Now, in the old days, I mean, there'd be a famine, or there'd be an illness, or we'd have to go off, on long treks, and you'd use up some of those calories. And then, next time you have food, you fill up those stores again. And so there is a complex biology that allows you to actually take up more calories than you need at any given moment. Then we have this amazing tissue, which is fat tissue, which then converts these calories into something and stores them off, and it stores them safely. So, the adipose tissue or fat tissue can actually store those calories for years and years and years. And I sometimes joke about it. I said, you know what? You could be living off the pizza you had 10 years ago, because, that pizza was converted to fat tissue, and it went there and sits in your fat tissue till you need it. And that's what it's there for. And so protecting those energy stores is a vital function. It's as important to survival as everything else, that the body controls. And so although we get fooled by the day-to-day fluctuations in body weight, or I don't eat for a few days and I lose weight and then the weight comes back. And so we think this is something we can control, but actually there's a very complex biology behind this that really makes sure that our energy stores are protected. Unfortunately, the way the system works is that it is designed to continue moving up. And this is, I think, one of the biggest issues around the way that the biology works. This happens pretty much, starting from infancy. The set point keeps moving up and kind of matches the highest weight that you've achieved. That then over time becomes your new set point. But there is no biology that allows the set point to move down. Because that was you never have to go back to 6 pounds, right? I mean, once you're at 70, or 80 pounds or 100 pounds, well, that's not what it evolved for, right? And so unfortunately, what happens when you gain weight is that, the set point keeps going higher. And usually it settles around your maximum weight. So it's your lifetime maximum. And so that's one of also the important history questions, right? One of the questions you would ask your patients is, not counting pregnancies, what's the maximum weight you've ever been? And for most people, that maximum weight is actually the weight that they're fighting when they try to lose weight. No matter how hard you try, very often it's very hard to get beyond that plateau. And from a clinical perspective, that of course is extremely frustrating for the patient. But from a biological perspective, all that tells us is that, well, you've got a normal working biology that is trying to defend you against losing too much weight.
I'm smiling throughout all of this as an educator because the value of this explanation and understanding this biology is crucial. And I think having this applied to what we do and how we teach in the exam room is essential. So how does that change our responsibility in the exam room? If a patient comes in and we're only offering lifestyle advice, are we really practicing evidence-based medicine, or are we falling short of our professional standards?
Lifestyle advice is important, right? Because there's always things that everybody can do to improve their lifestyle, right? Or, whether it's making healthier choices, whether it's trying to be more active, whether it's reducing screen time, whether it's reducing stress levels. They're always important. And in fact, they're important for everybody, right? And so, if somebody came to me with diabetes, I'd probably give them the same advice. Well, you got to have a healthier diet. You need to be more physically active and do all of those things. If somebody came to me with hypertension, I'd probably give them the same advice. In fact, if somebody came to me with pains in their knees, I'd also give them the same advice, right? Because we know that, physical activity is so important, right? So the question is it enough? Right? Is it enough to actually manage obesity in the long term, right? Because what we're looking for is not a short-term solution, where you lose 20 pounds in a couple of weeks and that's it. But if you're talking about significant obesity, we're talking about people who probably need to lose, 20 pounds, 30 pounds, 40 pounds, 60 pounds, maybe 100 pounds. That kind of weight loss is not something that you can sustainably achieve, by walking your dog. It's going to take a lot more than that. And if people remember the Biggest Loser as an exercise, if you look at the amount of activity that was being done there, people were exercising till they threw up. That's a crazy amount of activity. On top of that, they were severely diet restricted, right? They were eating 900, 800 calories a day. If that's all you're going to eat, I can guarantee you that you're going to end up with nutritional deficiencies, right? There's no way that anybody can survive in the long term forever if all you're eating is 1,200 calories, right? That's simply not going to work. So lifestyle interventions alone are not going to be effective enough for the vast majority of people who have a significant amount of weight to lose, right? You can get there, but that's not what we're looking for. We're not looking for, people to get there. We're looking for people to stay there. And that's a whole different story.
We talk a lot about reshaping narratives as an organization for strategic purposes for Obesity Canada. We hear a lot about diagnostic overshadowing, where a doctor sees a large body and assumes unhealthy or non-compliance before asking appropriate questions about a patient's health. So this stems exactly from what you were saying. How does understanding the definition of obesity as an impairment of health, not just appearance or size or BMI, help dismantle that bias and change the way we assess and talk about health risks? And how does EOSS help us do that more effectively?
Well, the Canadian Obesity Guidelines, of which we the first version of which we published back in 2020, was really the first guideline that defined obesity as being the presence of excess or abnormal body fat that impairs health. And it's really the health impairment part of it that makes this interesting for us medical folks, right? If this was just a shape and size thing, and that's important. Aesthetics is also important. But if it was just an aesthetic problem, then it's not really a medical problem. They have to be affecting some aspect of health. And you can look at the potential effect of excess body fat on health in 3 dimensions, right? So we've got the medical complications. And the medical complications would be, say, high blood pressure, sleep apnea, type 2 diabetes, osteoarthritis. The list goes on. There's 200 conditions that are either directly related to obesity or get a lot worse if you also have obesity. Okay, so that's the medical side of things. But then we also have the mental aspect of obesity. So right, and you find people that their blood pressure is normal, they don't really have any metabolic issues, but they might have other problems, right? They might have poor body image, they might have emotional eating, they might have depression, they might have anxiety disorder. There's all kinds of sort of emotional issues that can come with obesity or that can actually drive obesity. The mental health issues related to excess body weight are actually part of the problem. And then we have functional limitations. And these are people, they may be metabolically healthy, they may feel great about themselves, but they're simply not able to function the way that they would like to function. There's things that they just cannot do because of their size, or they find more difficult to do because of their size. And that can impair your health, and that in turn then can lead to, mental health issues, and that can in turn can ultimately also lead to sort of metabolic issues or other health problems, right? So when you look at those three dimensions of health, your question is, if obesity is impairing health, well, which of these three dimensions is it really affecting the most, right? Are we talking about metabolic health or medical problems that the patient has? Are we talking about, mental health issues, or are we talking about functional issues? The strange thing is that this is not really very size dependent. It's not the amount of body fat that's the problem. It's the type of body fat and the location of the body fat. It's a little bit like real estate, right? Obesity, it's all about location, right? So you could have a lot of body fat that's just sticking underneath your skin. That is usually not the problem when it comes to metabolic disease. Now, obviously, if you have a lot of that fat, that means that there's a mechanical load, on your knees and on your feet and maybe around your neck, and so you're talking about mechanical complications of just having all of this fat, but it's not really leading to any metabolic problems, right? And that's subcutaneous fat, right? Then we have what we call visceral fat. Now, that fat is a fat that's located inside your abdomen and around certain organs. So, this is fat that could be wrapped around your heart. So we talk about epicardial fat, we talk about perirenal fat. And these are natural fat depots. So we do have some fat there naturally, but those fat depots, when they increase in size dramatically, that can cause a lot of problems. So that's visceral adiposity. And then we have ectopic adiposity or ectopic fat, and that's when you start putting fat in organs where it really doesn't belong. And the best example for that is the liver, right? So when you start having a fatty liver, when you start having fatty skeletal muscle where you really don't want a lot of fat, that's really when a lot of the metabolic problems start, right? Because that causes insulin resistance and local inflammation, et cetera, right? So one of the things that we've learned is that it's not the total amount of body fat, but it's the kind of body fat, it's the location of the body fat that ultimately determines whether or not you're going to be having any of those health impairments, especially the medical health impairments. So what that means is that if you're trying to define obesity or look at the severity of obesity in terms of how severe are the medical problems that you've got because of excess body fat, body mass index, or in fact, even body composition measures don't really give me the information on that, right? And so we had to come up with another way of looking at this. We said, okay, we can make the diagnosis obesity based on body mass index. That's okay, right? But the clinical diagnosis really should be based on, so what are the health impairments that this patient has? And for that, we got to actually do some lab, we got to take a history, look at what are the problems. And so we came up with this staging system that was really based on these clinical indicators. And because I was in Edmonton at the time, it became to be known as the Edmonton Obesity Staging System. And in fact, now it's worldwide pretty much the most popular system. I know that the clinicians love it. The researchers find it a little bit difficult because, but it wasn't designed for research. It wasn't designed for science. It was designed for clinical decision-making. That is, I do the Edmonton obesity staging in my patient. I know how severe the obesity is. And that, of course, then guides my treatment decisions. So, and that's what it was really designed for. And it works great for that.
This is such an amazing conversation. I wish we had more time to go over EOSS in more detail. As an educator, as someone who teaches medical students here, I speak on EOSS as much as I possibly can to explain the importance of, I sometimes actually talk about it like a disease-illness dichotomy, even though it's not exactly the same, but the importance of recognizing of a lot of the functional impairments that we can see as a result of the disease. This is obviously more in line with the grading and staging that we see with a lot of other diseases and looking at it that way, but really understanding the person more than just what you see in front of you. I think is also really powerful and really important. And we need to have this in our education system from day one when we talk about obesity. And I think that's something that we're going to continue working on.
Yeah, and I think what we also have to understand from day one is that the whole blame and shame strategy that we've been using for simply does not work, right? And the only thing that's going to guarantee is that that patient might never come back or feel even worse about themselves. And in fact, we do have data showing that the more weight bias or discrimination or shame and blame that patients experience from their healthcare provider, the less likely they actually are to follow up. And very often, the notion is that, if they sit in front of me and they leave my office with shame and blame, their next stop is going to be the donut shop, right? Because that's the normal response to not feeling good about yourself. If the result of anything I do in my practice is the patient leaving my practice not feeling good about themselves, I haven't really helped them much, right? In fact, I've done the exact opposite. And so I think the first thing we need to do in this is use compassion. Understand this is a tough fight. This is not an easy fight. It's a cruel disease, I say, because it impacts every single aspect of your life. And so I think we do need to approach every patient with understanding, with love and compassion, and say, I don't have a simple solution for this, but I'm here to work with you. And that's why when we look at the 5 A's of obesity management, the most important part of this is the advice and the agree part. Because at the end of the day, I can give you all the advice I want, but at the end, we're going to have to agree on the course of action. And that course of action, at the end of the day, has to lead to results that reduce the burden of obesity, whether it's the health burden, whether it's the mental health burden, whether it's the functional burden, because that's what managing this chronic disease ultimately is about.
What does the future look like, Dr. Sharma, if we were to incorporate this knowledge into our practice from an early stage around bias, around stigma, around the biomedical basis of obesity as a chronic disease? How does the conversation in the clinic change? What's the vision look like from your standpoint, from someone who has seen so much and contributed so much to this field?
Well, the vision for obesity has been from day one to make sure that people who have obesity as a chronic disease get the same respect and level of care that anyone with any other chronic disease gets. When people come to a clinic with diabetes, there's a standard of care. It includes lifestyle advice, it includes education, it includes medication, it includes whether this is an insulin pump or whatever it is, right? I mean, there are treatments. You have access to diabetes treatments. You come to a clinic with hypertension, well, there's hypertension treatments that you have access to. You come to a clinic with heart disease, well, you have access to treatments for heart disease. These are all chronic diseases. And the vision is that hopefully within the next 4 or 5 years, anybody who comes to see a doctor or a healthcare professional with obesity gets the same level of respect, the same level of understanding, and has access to the same level of treatments. Whatever those treatments are, those treatments can be, they could be psychological, they could be behavioral, they could be medical, they could be surgical, whatever the treatment is that would be best for this patient, they would have access to those treatments. But because right now what we have is a completely unfair situation. So if you have diabetes, you get all the care you need. You got heart problems, you get all the care you need. You got sleep apnea, you get all the care you need. You have obesity, now you're on your own, right? With no access to any of the treatments that actually work and that are actually good for you. And even if you had the access, then you got to jump through all kinds of hoops. If you look at bariatric surgery, still being perhaps the most effective treatment for obesity, even today in most provinces, perhaps with the exception of Ontario and maybe Quebec, most people still have a hard time getting surgery. And I don't even get me started on access to medication, right? Because that's almost hopeless.
Don't get me started either as a family doctor.
It's unfair, right? Because the science tells you that these medications and these treatments actually work, and they improve the lives of our patients. They reduce the health burdens, and I'm hoping that in 5 years, most patients or the vast majority of patients who are living with obesity will actually have access to these treatments.
Today, listeners, we unpacked the biological reality of obesity. We defined it not as only as a behavior, but as a multifactorial chronic disease defended by the brain. We also discussed how deep biomedical knowledge is actually your strongest tool against bias. When you understand the physiology, judgment gets replaced by curiosity. Dr. Sharma, thank you so much for being here. Listeners, if today's conversation sparked questions and curiosity for your practice, check out the show notes for links to Dr. Sharma's LinkedIn page, ICHOM, ICHOM, outcome measures, and the Edmonton Obesity Staging System, or EOSS, so you can dig deeper into the evidence. Again, thank you, Dr. Sharma, for being here. This was an incredible episode, and I am so grateful I had the opportunity to talk with you today.
Well, great talking to you, and thanks for having me.
So remember, listeners, new episodes of Scale Up Your Practice drop every second Thursday. Make sure you are subscribed so you never miss an episode. If you found value in today's discussion, please take a moment to rate and review the podcast or share it with a colleague. Until next time, stay curious, stay kind, and keep scaling up your practice.